Okay, so now we're going to move on to chapter 14. And this chapter is about drugs used to treat neurodegenerative disorders. So please review your chapter 14 objectives. And I'm going to dive right in at slide number 5. Okay, so the first one on the docket is Parkinson's disease. So with Parkinson's, normally there's a balance between neurotransmitters. So you got your dopamine neurotransmitters, which are having an inhibitory effect. So inhibit means it's inhibiting. And then you have acetylcholine, which is an excitatory effect. Symptoms are caused by the deterioration of dopamine neurons, which results in a deficiency in dopamine. So let me say it again. So symptoms are caused by the deterioration of dopaminergic neurons, resulting in deficiency in dopamine. So if you look at the bottom of slide 5, I put in what a normal neuron or a dopaminergic neuron should look like. Neurons are neurons, but this is called because it's dealing with dopamine. In Parkinson's disease, if you look at the bottom of the slide, remember at the dendrites where the neurotransmitters, the chemicals exchange so the neurons can talk to each other? Okay, there's an issue there in that space with dopamine, okay? There are 2 types of Parkinsonism. Primary is is primary Parkinsonism, which is a idiopathic, meaning it has an unknown cause. They don't know why the patient has it or got it. Secondary Parkinsonism can be induced by head trauma, infection, tumors, or drug exposure. Now, keep in mind, Parkinson's is a progressive disorder of the central nervous system. Parkinson's is a chronic progressive disorder of the central nervous system. What's our central nervous system? The brain and the spinal cord, right? So this was named after James Parkinson. He was an English physician who described the shaking palsy in 1817. So in Parkinson's disease, the inhibitory effect, remember we said up top in the top of the slide, dopamine has an inhibitory effect. So this refers to a significant impairment in ability to suppress unwanted movements or behaviors, often due to a decline in dopamine levels in the brain. It's the central nervous system, right? So let me say it again. The inhibitory effect refers to a significant impairment in the ability to suppress unwanted movements. So you can't suppress them. That means they're shaking or they got tremors, that thing. It's an inability to suppress unwanted movements or behaviors. It is due to a decline in dopamine levels in the brain, leading to difficulties with motor control. That's why people shake and have tremors. So it leads to difficulties with motor control and causing symptoms like tremors, rigidity, and slowness of movement. So they may have this slow movement. They may walk slow. This deficit is particularly noticeable in the brain regions responsible for inhibitory control, like the basal ganglia, impacting a person's ability to stop actions once they're initiated. So what that's saying is once those dopamine receptors are their decline, so these movements start and the patient has no control over them, basically is what that's saying. So now when we speak on Parkinson's, on with the acetylcholine, remember, that's the excitatory effect. So what that means is it stimulates the neurons. So go back, it stimulates the neurons due to an imbalance with dopamine, where the loss of dopamine in the brain leads to excessive acetylcholine activity. So let me say it again. So when there's a decrease in dopamine in the brain, this leads to excessive acetylcholine activity. So that's why it's excitatory, right? Contributing to the motor symptoms. So that's what make people motor parts do that thing of the disease. This imbalance is thought to be a key factor in the development of Parkinson's movement disorder. And your Parkinson's information starts on page 204. So just to recap really quick. So with Parkinson's, it affects the central nervous system. Our central nervous system is the brain and the spinal cord. So often we have declining levels with dopamine, and because of that, the acetylcholine is in excess, and because that controls your motor movements, this is why you see people with the movement and the tremors, okay? So now I'm going to move on to slide number 6. I'm sorry, because I'm doing the slides to kind of see what's on them so I can explain a little bit. Okay, so we're on slide 6, chapter 14. Parkinson's disease. So it is both progressive and incurable. So the disease is going to continue to progress, and there's no cure for it. The goals of treatment are to moderate symptoms, or make the symptoms moderate, and you know, where a person feel like they're kind of controlled a little bit, and slow the progress of the disease. Constipation is a frequent problem. Motor symptoms usually begin on one side of the body, so you may only see the tremors or certain like body movements on one side of the body. Eventually, the patient has postural and gait alterations. So they may start to bend over, or they may start to have what we call a shuffle gait. They shuffle their feet and walk really slow. Nurses can have a major influence in the positive use of coping mechanisms as the patient and family express varying emotional responses, because the family is going to be very emotional in a situation like this when their loved one is going through this disorder, okay? Slide number 7 is a question. You can answer that, and we can do that during the Q&A. I'm going to move on to slide number 8, and we're going to talk about the drug therapy used for Parkinson's. Okay, let me get my slide on slide number 8 on my PowerPoint. So, with Parkinson's, the goal is to minimize the symptoms. There's no cure. So, we want to restore that dopamine activity and restore the neurotransmitter function. We want to slow the deterioration of the dopamine nerve cells, and we want to inhibit excess cholinergic activity, and that's what causes the tremors. So your cholinergic activity goes back to your acetylcholine, because that's your neurotransmitter, right? Which causes cholinergic activity, which causes the tremors and the movement. Effectiveness of the therapy may take several weeks. Parkinson's therapy is individualized per patient, and it uses a combination of agents because symptoms and disease progression vary greatly among individuals. Therapy begins when symptoms interfere with the ability to function in daily life. Although seldom used in older adults, anticholinergic agents provide symptomatic relief from excessive acetylcholine. All right, let me say that again. Although seldom used in adults, although anticholinergic agents are seldom used in adults because, but they provide symptomatic relief from excessive acetylcholine, which causes the movements. Okay. Slide number 9. So we're going to talk about assessment, nursing implications for Parkinson's disease. So you're going to do an assessment. They have what they call a unified Parkinson's disease rating scale. And you can see that on page 206 in your textbook. Is there a family history of Parkinsonism? Assess their motor function. Are they having uncontrolled shaking, tremors, dyskinesia, impairment of the individual's ability to perform voluntary movement? They're shaking so bad they can't tell their hand to pick up their cell phone. That's impairment of ability to perform voluntary movement. Voluntary means they're doing it on purpose. Bradykinesia, extremely slow body movement. So you might see them with what they call a shuffling gait, because their movement is slow. And akinesia is an actual lack of movement, right? Refer or review figure 14.2, and that's again page 206 in your textbook. I'm going to move to slide number 10. So slide number 10 is talking about nursing implications for Parkinson's disease. So, what's the facial appearance? What's their nutritional status? Salivation. Are they mouth so dry they don't have any saliva? Psychological. Is there any stress? That's an issue. Is there safety and self-care issues? What's the patient's family resource support? A nursing implication is the potential outcome of a nurse's actions or inactions. They are a crucial part of nursing practice, helping nurses make informed decisions that improve patient care. So let me say that again. So when we're talking about nursing implications, this is the potential outcome of a nurse's actions or inaction based on what you do or don't do. They are a crucial part of nursing practice, helping nurses make informed decisions that improve patient care. Implement planned interventions that are consistent with assessment data. See page 206. Educate your patients on nutrition and stress management, self-reliance, exercise, mood alterations, fostering health maintenance, and patient self-assessments. You should always be self-assessing yourself. Am I eating good? Am I trying to get enough exercise? Am I sleeping well? Am I eating good? That's the patient's self-assessment of themselves or where they think they are. Okay, so we're going to move on to slide 11 is a question. You can answer that, and we can go over that at the Q&A, and so is slide 12 is a question. You can answer that. We can do that when we do the tutoring Q&A. And so I'm going to move to slide 13. Slide 13. Okay. So now we're getting ready to get into monoamine oxidase type B inhibitors. Short MAO/B inhibitors. Okay. They are used early during treatment to slow the progression and symptoms of Parkinson's. They help establish a balance of dopamine and acetylcholine in the basal ganglia of the brain. Affects the central nervous system, brain, spinal cord, right? So now you got these drugs that prolong dopamine availability. So let me say it again. Your MAOBs prolong dopamine availability. So if we're prolonging the dopamine in that neurotransmitter space, that means that the symptoms are less because the dopamine is prolonged over a time where those symptoms get minimized. Okay? Your MAOB inhibitors are a class of medications that inhibit the enzyme. It inhibits the enzyme MAOB, which is responsible for breaking down dopamine in the brain. So if it's inhibiting the dopamine, if it's inhibiting the enzyme MAOB, which is responsible for breaking down the dopamine in the brain, that means it prolongs the dopamine availability, right? They are primarily used to treat Parkinson's disease, a condition characterized by low levels of dopamine. Please refer to Table 14.1 in the textbook, page 208. Let's move on to slide 14. So, we're still talking about our MOAB inhibitors. Let's recap. So, your MAOB inhibitors inhibit the messing with the dopamine. So that means dopamine lingers in that chemical space longer. So then the symptoms of Parkinson's is decreased or minimized, right? So with these, you want to do a pre-medication assessment. Where is your patient's status prior to starting the medication or it being prescribed to the patient, okay? What's again is the availability, doses, and administration. Those are teaching moments. Common adverse effects with these is constipation, upset stomach. Serious adverse effects neurologically is chorea, confusion, and hallucinations. Cardiovascular wise is orthostatic hypotension. These again are on table 14.1 on page 207. Just for a quick FYI for your neurological career is that involuntary movement disorder characterized by brief, irregular, and dancing-like movements. This goes back to that dopamine piece, right? It's because if the dopamine is decreased and your acetylcholine is increasing, it's exciting. That's where you get this movement from, right? So that's kind of what chorea is that involuntary movement, okay? Let's move on to slide number 15. Okay, so now we're talking about dopamine agonist. So remember, it's not an anti. So your agonist is going to help contribute to the dopamine, right? Because the dopamine is what the problem is in Parkinson's. So if you have a dopamine agonist, that's going to also help boost your dopamine, which is going to decrease those Parkinson's symptoms, right? So the most common ones you're probably going to see, and it's given in combination, is your carbidopa and your levodopa. The action of carbidopa, it reduces the metabolism of levodopa, so more of the administered levodopa reaches the receptor sites. Levodopa is used to replace dopamine deficiency in Parkinson's. So it's helping with the Parkinson's, okay? The brand names you might see is Cinnamon. It's the most common one you're probably going to see. And about 75% of patients with Parkinsonism respond favorably to levodopa therapy. All right? Let's move on to slide number 16. So we're still talking about carbidopa, levodopa. So the common adverse effects you're going to see is nausea, vomiting, and anorexia. Your serious adverse effects you're going to see with this is chewing motion, bobbing or facial grimacing, rocking movements, sudden sleep events, nightmares, depression, confusion, hallucinations, tachycardia, and palpitations. And you can see different drug interactions with this kind of therapy in your text on page 212. So let's move on to slide number 17. So your patient education. When your patient is taking levodopa, You want to discuss the expected therapeutic outcomes, explain the many adverse effects. Most of them are dose related and are reversible. Okay. Tell them they can expect orthostatic hypotension, so they need to get up slowly from a supine or sitting position. If they feel faint, to sit or lie down. They need to monitor their blood pressure daily. So again, refer to your textbook for specific discussions about medications, and I think those are going to be in that same area around page 212. Okay, slide number 18 is a question. You can answer that, and we can do it when we do the Q&A and tutoring on Monday. And now I'm on slide number 19. So, slide number 19, we start to talk about COMT inhibitors. So, these particular drugs reduce destruction of dopamine in the peripheral tissue, allowing more to reach the brain. Okay, let's dissect that. So, your COMT inhibitors, they decrease the destruction of dopamine. So that means if the dopamine are not being destroyed, you got more dopamine hanging around that neurotransmitter space, right? In the peripheral tissue, so peripheral, right? So that more can reach the brain because it affects the central nervous system, which is the brain and the spinal cord. Let me say it again. So your COMTs reduce destruction of dopamine in the brain, dopamine in the peripheral tissues. So dopamine in the peripheral tissues, allowing more of it to come up and reach the brain. So if you got more dopamine in the brain, you got less of this activity, right? They are added to treatment when carbidopa and levodopa becomes less effective and adverse effects develop. So you might see a COMT inhibitor when the carbidopa, levodopa, they feel like it's no longer working the way it was, it's less effective, or they have adverse effects that develop. Common adverse effects of the COMTs is diarrhea. They may have a sedative effect and urine discoloration. You need to know to teach your patients. If they're taking a COMT, your urine may turn brownish orange. You don't want a patient to freak out because they go to the toilet and their urine is not yellow. So, your COMT inhibitors are a class of medications that inhibit the enzyme COMT, which is a long name, catechol-O-myelotransferase. So it's short COMT. This enzyme breaks down dopamine, a neurotransmitter that plays a crucial role in motor function. Okay? So make sure to go over that. The serious adverse effects with these meds are chorea, so you got your movement, right? Confusion, hallucinations, and orthostatic hypotension. So your patient education is going to tell your patients to get up slowly from a lying or sitting position, and if they feel faint, to sit or lie down, right? Okay, we're going to move on to slide number 20. Okay, so slide number 20, we're going to start talking about anticholinergic agents. So the action of these meds reduce hyperstimulation caused by excessive acetylcholine. So let me say it again. So anticholinergic agents reduce hyperstimulation caused by excessive acetylcholine. Remember, when dopamine decreases, acetylcholine comes up. It's a hyperstimulant. That's why you get excessive movement. So it reduces that acetylcholine process. It's used to reduce the severity of the tremors and drooling associated with Parkinsonism. Common adverse effects is constipation, dryness of mucosa and mouth, throat, nose, urinary retention, and blurred vision. Again, it goes back to you can't pee, can't spit. All right? For specific drugs in this class, please see table 14.2 on page 210. These are less effective for rigidity. So sometimes Parkinsonism, they'll be rigid. These meds are less effective for that. They're less effective for the bradykinesia, the slow movement, and postural abnormalities. Like, remember we talked about the posturing. These are a little less effective on that thing. So more useful for patients with minimal symptoms and no cognitive impairment. So your anticholinergic agents work better for patients with minimal symptoms and no cognitive impairment. The serious adverse effects of these are nightmares, depression, hallucinations, orthostatic hypotension, palpitation, and dysrhythmias. So it can disturb the heart pattern, right? Okay, let's move on to slide number 21. So I don't know how we switched from those, but we're going straight to drugs for Alzheimer's. So don't get this confused. So now, starting on slide number 21, we're going to talk about drugs that are used for Alzheimer's disease, okay? So the drug therapy focus is on improving cognitive function, because you have to remember with Alzheimer's, there's a dementia or memory loss. So the focus of therapy with Alzheimer's is improving cognitive function. So now we got two classes with Alzheimer's. The acetylcholine inhibitors and your N-methyl deaspirate, or you'll hear referred to as NMDA inhibitors. All right. We need to educate. Education is focused on caregiver with regarding to how to manage declining cognitive abilities of the patient. And again, if the patient is able and or family member, that patient's self-assessment. Today, no drugs are available to slow the degenerative process of Alzheimer's. Okay, so let's talk about these acetylcholinesterase inhibitors. I'm on slide number 22. I apologize, y'all. Some of these are a mouthful. The most common one you probably are going to see is that donepezil. The primary therapeutic outcome of this is to improve cognitive skills. Common adverse effects is gastrointestinal. So again, there's your nausea, vomiting, dyspepsia, diarrhea. Serious adverse effects can be cardiovascular wise, is bradycardia, so it will slow the heart rate. Your ACHELs are drugs that block the action of the enzyme that acetylcholinesterase, and it's responsible for breaking down neurotransmitter acetylcholine in the body. You can see this information on page 224. Okay, so we're still talking about these. We're going to go back to the NMDA receptor inhibitors. That's going to be on slide 23. The primary therapeutic outcome of these is to help improve cognitive skills. Common and serious adverse effects, again, is neurologically, you got headache, dizziness, akinesia, insomnia, restlessness, increased motor activity, excitement, and agitation. Okay, so these NMDA receptor antagonists are a class of drugs that work to antagonize or inhibit the action of this N-methyl deaspirate or your NMDAR receptor. That's what the R means on the end. They are commonly referred to as dissociative anesthesia. So take a peek at those as well. This concludes chapter 14. Bring your questions or answers to the questions, and we can go over the questions for the Q&A tutoring on Monday. And we got one more chapter to go. I'm going to stop this video and take a little break, and then I'm going to come back and finish with chapter 15.